Welcome everybody to the AMN Bootcamp. This session of ALD Connect is dedicated to standards of care for AMN. And my name is Florian Eichler, and Brian Wishart from Physiatry at Mass General has also joined me. And together we will first discuss rationale for gene therapy and symptomatic treatments, and then have Dr. Wishart speak to his practice and way of thinking through signs and symptoms and needs of men with AMN. Let me start off with a disclaimer of ALD Connect. Please note that this webinar is for informational purposes only. The discussion is not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you are a family member or are ill or suspect that you are ill, seek professional medical attention immediately. ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned on this webinar. So my personal disclosures are listed here. So I thought I would start with some basic facts, and many of you listening may already know this, but some patients, family members, or caregivers may be new to this field, and it always helps to remind people of the basic facts of ALD and AMN, and what the relationship between adrenoleukodystrophy and adrenal myeloneuropathy is. So X-linked adrenoleukodystrophy is a single gene disorder. It arises due to a mutation in this gene called ABCD1 that encodes a protein. This protein sits on a particular part of the cell called the peroxisome, and it's responsible for importing lipids into the peroxisome. And this peroxisome acts a little bit like a trash can for these very long chain fatty acids. And if this protein is dysfunctional, if it doesn't work well, then that import of lipids does not happen. These lipids build up, so-called very long chain fatty acids, and they are used to make the diagnosis of adrenoleukodystrophy, and are also used in newborn screening today. The part of the nervous system that is most affected in ALD is the so-called corticospinal tract, these very long tracts that run down from the brain through the spinal cord and send signals to our muscles to activate and to contract, which is why we have problems of weakness, problems of tightness in the muscles. But there's also another important tract that is affected, and this is a tract that runs from in the opposite direction a lot in the spinal cord. It's called the sensory tract of the dorsal columns. So it runs in the back of the spinal cord and brings sensory information from our peripheral nerves, from our joints, and up into the brainstem and the brain. And this is the tract that's responsible for changes in sensation, for changes in balance, but also our bladder function. And so these two tracts are the most common ones to be affected in adrenoleukodystrophy. and in particular in adrenomyeloneuropathy. And adrenomyeloneuropathy is the adult form of adrenoleukodystrophy. It is the most common form of adrenoleukodystrophy. It's called myeloneuropathy because it's exactly the spinal cord, myelo, and the peripheral nerve, neuropathy, that is affected. Okay, so now I'm going to briefly switch gears to talk about approaches to gene therapy. Many of you may have heard about gene therapy being used in boys with childhood cerebral ALD. This is an ex vivo gene therapy approach where cells are taken from the boys themselves, transfected in a dish with a certain virus carrying a corrected gene, and then those cells are given back to the boys, and they go from bone marrow to blood and from blood to brain. This is what we call a cell-based delivery approach, an ex vivo gene therapy approach, usually employing certain kinds of viruses we call lentiviruses. This is very different than the in vivo gene therapy approach, where direct delivery of the therapeutic gene occurs and is usually packaged in a virus, usually something we call an AAV, and is directly injected into either a target organ, or in the case of spinal cord diseases, often inserted into the spinal fluid surrounding that spinal cord. But it does not require cells to be taken out of the body as the ex vivo gene therapy approach requires. And so this just also shows these two differences between the in vivo gene therapy that uses these small adeno-associated viruses, often called AAVs, and the ex vivo approaches that uses the larger lentiviruses. And here an illustration of the same thing I just talked about, that with the ex vivo, you're taking cells from the boys, transfecting them, giving them back. What we're planning for the adults is a different approach with the in vivo gene therapy, where we're taking this adeno-associated virus and delivering directly into the spinal fluid. More about that later. So why are we using that approach with AAVs? One of the reasons is the big success that has been shown in a related disorder called spinal muscular atrophy. Some of you might have heard about this as SMA, and this has been very transformative treatment for babies and young children affected by this. And the reason we look at SMA is because the disease also affects the spinal cord, and a particular part of the spinal cord called the lower motor neuron. And that sits in close vicinity, proximity to the structures that I talked about before, which are affected in AMN, namely the corticospinal tract, the long tract sending signals down to the muscles from the brain, and the dorsal columns. Those tracts are coming up from the periphery and bringing sensory information to the brain. So because an SMA was so successfully treated by AAVs, we decided to employ a similar approach for AMN, and we packaged the gene ABCD1 into an AAV, and we were able to show that we could, in cell culture, successfully deliver this therapeutic gene to brain cells and get them to go to that particular compartment of the cell that I talked about earlier, namely the peroxisome. And to our surprise, when we did this in a mouse that lacked ABCD1, we could deliver very nicely into the ventricles and also intravenously, and we're able to lower the very long chain fatty acids that accumulate in this disorder. So we had a nice proof of concept that yes, gene therapy could be possible for AMN as well. And this led us to pursue this approach further and to further develop way to target the spinal cord more effectively using an osmotic pump that is in the mice inserted under the skin and allows for direct delivery into the spinal fluid, increasing that targeting of the spinal cord where these two tracts are that we need to correct. It also helps reduce leakage into the blood system where we really don't need the therapeutic gene as much as we do around the spinal cord. And just to show you the kind of work that's needed to bring this forward to a treatment, we next showed that in the mouse, we were able to use now the ABCD1 protein itself packaged into an AV and delivered through this pump, and we were able to get into the right cell types, astrocytes, neurons, and some other glial cells in spinal cord. But importantly, we were able to lower the very long chain fatty acids shown here in spinal cord, the ratios of C26 to C22 and C24 to C22. So I want to now transition over to why the sensory tracts are so important, and also provide a little bit of a background for Dr. Wishart to then follow in terms of his rehabilitation efforts. We've known about AMN since the 1970s, and it was work both at Harvard and at Hopkins that laid the basis for this. It was really the discovery that these tracts in the back of the spinal cord, you can see that this area is not as dark as the surrounding area. And similarly here, you have some lightness. These are the areas where you see that these tracts that usually deliver information up to the brain are affected. And the nerves that lead from the periphery to the spinal cord, you have to go through a specific structure called the dorsal root ganglion. And this is a very important structure for AMN. And it is a structure rich in neurons and supporting cells. And there's a lot of metabolic activity here. And there are also some of the highest very long chain fatty acids in the nervous system in this structure. And so we've spent a few years studying this, but it was the very first discoveries were by a pathologist named Jim Powers, and he was able to show that these DRGs are really critical. A lot of lipids build up within that structure. And in normal people who don't have ALD, there is a lot of ABCD1 expressed in the neurons, showing how important ABCD1 is to this particular structure. It's a little bit like an area where the traffic junction occurs and signals are sent from one end of the nerve to the other. So this sensory dysfunction is really responsible for the kinds of balance and bladder problems that affect patients with AMN day to day. And we've been studying the different components in the dorsal root ganglia and the kinds of things that happen to neurons. But if you don't have the proper sensation and signaling coming from the periphery to the brain, often your body doesn't understand where your joints are in space. And that is exactly what happens in AMN. So beyond the weakness and the tightness, you also have trouble getting the signals from the limbs up into the spinal cord and the brain. And your bladder is also one that is affected by that sensory dysfunction. That we've learned that a lot of the signals that your bladder gets are signals of overactivation, and often the pressure and the stretch leads to certain channels called piezo2 channels to send signals into the peripheral nerves and up into the dorsal root ganglion. And that information is sent too readily, leading often to the sense of urgency and overactivation. And we've studied urinary and bowel symptoms in AMN and published a first large paper on this. This has been something that has largely been neglected in neurology, but for the first time we were able to really summarize and demonstrate that really more than half of the women and men suffer from some bowel and bladder problems over their lifetime, and it really affects them on a daily basis. And more importantly, if you have problems with gait and tightness in the muscles, often getting to the bathroom is very difficult, and that in addition creates problems and leads to accidents. So this is something that is now being increasingly recognized, and we have a very good urologist you'll be hearing from shortly at 1 o'clock, Dr. Pablo Gomery, who can speak to his recommendations on how he practices and manages these kinds of symptoms. But you have to differentiate between urinary frequency, hesitancy, urgency, and similarly with the bowel symptoms between incontinence, constipation, and depending on each individual person having different kinds of symptoms, different regimens and different medications can help. So for gait and balance, I've also hopefully convinced you that it's important to have these sensory tracts work well and send information from the periphery to the brain. And it's often information not only about where your joints are in space, but also what kind of visual information is coming in. And we've been able to study that in a certain kind of lab called a vestibular lab. That's really a lab dedicated to balance problems and patients who experience dizziness. And we've been able to use those exact tools that are employed for patients who have dizziness to serve AMN patients. And we've been examining what happens when the surface that you stand on is uneven, what happens when this visual surrounding starts to change. And it turns out that when you start changing the surface and also the visual surroundings, you, not surprisingly, aggravate the sense of balance. And this is something I think we have to increasingly recognize, that the balance problems are aggravated by eyes closed or by poor visual conditions, as often happens in the evening or when it's dark out, and also unevenness of the street or the floor or the stairs that you're walking on. And this is something you have to be very careful about, because it can lead to fall risk and aggravated symptoms. So I'm just going to close by summarizing here briefly that for successful AMN gene therapy, we understand that we have to get into the right target structures and cells. But the good news is that the newer capsids that we use for gene therapy are able to really cross the blood-brain barrier and deliver to those critical structures, the sensory pathways that I mentioned, the DRGs, that dorsal root ganglion, that are important transit locations for the nerves. And understanding those is important because sensory pathways are really responsible for bladder dysfunction and balance problems. But I'm going to end here by emphasizing that that the understanding of how to remain engaged with exercise, with physical therapy, with occupational therapy is essential. And because if you don't continue to use those long tracts that are under duress in the spinal cord, it is very hard to improve those symptoms. Simply performing gene therapy without continued rehabilitation and physical therapy does not make sense and will not lead to relief. It's we often say in neurology, use it or lose it. And I think this is something where we lean so heavily on our friends, the physiatrists, who are the ones who guide us through the process of physical therapy and occupational therapy. So I'm going to look at the chat and now briefly introduce Dr. Brian Wishart, who will talk about his practice and the enormous help that he's provided to my clinic in addressing gait and balance problems and many other symptoms that AMN patients experience. And I will in the chat start answering some of the questions. Thank you. Brian.
Thank you, Dr. Eichler. And thank you, ALD Connect, for having me here. Just get my slides up real quick. All right, so my name is Brian Wishart. I am a physical medicine rehabilitation physician at Mass General. I also practice at Spalding and through Harvard. And so no relevant disclosures. What I'd like to kind of quickly do, and I have only a few slides, so we'll sort of dig in a little bit as we go through, but just talk about some of the typical symptoms that we see in this myelopathy, and then just some of the general principles as we go through of what we're expecting with management, and what our goals and what we're planning on doing as we go through this. So it's a pretty diffuse disease that affects a lot of different aspects. You can see the areas that I've highlighted in yellow really apply to those long tracts that Dr. Eichler was speaking about earlier. So we see a lot of dysfunction within the aspects of our muscles, the aspects of our musculoskeletal system that help us with our balance, with our gait, with our mobility and ambulation. And it's sort of a multi-pronged hit that we see in AMN. So we get that spasticity, that tightness of those muscles. We lose that inhibition that keeps us from always tightening up and having these different patterns that we see as things get worse. And then with that, we also see issues with weakness. I would say compared to other diseases where we see spasticity, such as stroke or traumatic brain injury or cerebral palsy, we may see a bit more weakness underlying the spasticity in our patients with AMN. And so it's something to be thoughtful of as we go through it in terms of treatment. And then our balance issues, that proprioception is something that really kind of adds on another layer of issue as we're talking about what to do and how affected we are. So when we talk about those tight muscles, you know, there's a number of things that are helpful, and often these are not solely focused on what we're doing in terms of, okay, our muscles are tight, we want to stretch them out, or we want to use medications or something like that. But that base, this stretching therapy, bracing, that aspect is really what holds us together. That's our core, and that's what we're going to really use primarily in terms of maintaining our mobility, maintaining our function, and keeping us as active as possible, because I couldn't agree more. That idea of use it or lose it is going to be really important here. But we want to be thoughtful with it, I think, and that's one of the important parts, especially as we start talking about our older patients. When we talk about our young children that have had developmental issues, that's where we often are habilitating. They're trying to learn new skills as they go through. So it's often much more ongoing therapy, if you will, as we're going through. They go in once a week, they go in twice a week for sort of just an extended period of time. As we get older and we're trying to maintain what we have, we're trying to keep up our skills and keep up our strength, maintain our flexibility, improve our balance if we're having issues with that. It may be much more directed in terms of the therapy. So we may think about doing this in sort of short bursts. We want to do an 8-week course once a week or twice a week, focused on that proprioceptive. It's one of the things, there's a number of things within the therapy world, that proprioception, that balance, those aspects are something that's been shown to be really affected through intensive therapy. So focusing on that proprioceptive work, focusing on that balance can make significant gains and significant improvements as you go through the therapy. And I think when we see those things being affected, it's something that we really want to address with our therapists as we go through our, particularly physical therapy in that world. The other aspects of that, strengthening can be really important early on, in particular. The higher we are, the stronger we are from the beginning, the more range we have if we start to lose some of that strength. And then that spasticity can be really challenging at times. It really changes our gait. It makes us much more inefficient in our gait, and which is our primary goal when we start talking about how our body moves and how we kind of propel ourselves forward. The name of the game is really efficiency, and the more we can do to keep ourselves not working as hard the further we can go, the longer we can go, the less exhausted we are when we get there. And so those are the things I think about when we start talking about, do we need to do anything else after this kind of stretching? Do we need bracing that's going to help us with our efficiency and make it so we can go further and do more without getting as tired? Is just the stretching, the therapies, that can be helpful. Do we want to start talking about oral medications that may help with some of this tone and make it so we're not fighting our muscles quite as much, but we're able to keep going and have them work with us as opposed to against us more? That focal tone management can be really helpful at times, particularly when we talk about early on tone, and particularly in something like AMN where it's focused on the lower extremities, and we're not seeing really that global tone up into the arms, up elsewhere. And we may want to be a bit more specific about where we're affecting our muscles and not using something like an oral medication that may affect the entire system. There are other procedures out there for more advanced disease, from intrathecal backlift pumps. Selective dorsal rhizotomies are typically something we see in children. There's a few practitioners that are doing them in older adults. And then there's a number of orthopedic procedures, some other neurosurgical procedures, all sort of components of a good tone management plan. And I think that's one of the things that I've seen change as I've been going through this, really moving from sort of this left side where we start with stretching and bracing, and then we add on oral medication, and then we do injections, and then we think about surgery. The more of this circle where they're all within that same thought process. So early on, it may make sense to jump to something like surgery. It may make sense to just do injections along with our therapy. I would say that therapy is probably a baseline for most of it and going to be part of almost everybody's plan. But these different components, whether it's nerve blocks or more acupuncture, that type of stuff, or if it is oral medication that works for them, all of those can get kind of incorporated into a single plan. And we talked about this briefly. When we talk about our bracing, I think our objectives, our goals of care are really the most important thing to talk about from the front end. Nobody likes to move to braces. Nobody wants to see that we're putting on an AFO or we have to use extra support or we're going to need some sort of assistive device for mobility and safety. That said, when we start stepping away from, okay, well, what are we using? How are we getting there? And to why are we doing this? I think that's the most important thing you can think about as you go through this is our goal is to keep this functional, to keep up with life, to keep moving, to keep going forward. And if that means needing a brace to keep safe and prevent any further injuries, if that means using crutches or whatever it is, I think that those are the things that we should be focusing on. And the other side of that is when you start talking about, okay, further down the line, if we do end up getting to a point where we're having discussions about wheelchairs and that sort, again, it's much more about the idea that our goals are to get where we want to be and then be able to be functional there and not be so exhausted by the time we get to whatever our activity is for that day that we're unable to participate. And that participation is really the goal here. So often what we see when we get the correct bracing is we see improved stability, we see increased alignment, so we may correct, but often are accommodating for different spastic deformities or that kind of thing. Improved efficiency. This is the biggest thing that we're really aiming for here. And whether that means preventing a motion that we're not looking for or assisting weak muscles, one or the other can really help us move forward much better. And then, decrease pain, but really that increased function is our goal here. And the last thing I just wanted to talk about, because I do remember this from, I think it was the 2019 ALD Connect, somebody had mentioned that, I used to do all of these different sports and types of things. And that's just not in the game anymore. That's just not something I do. I'm not able to participate in those. So I've had to move to things that they enjoyed less. And I think that the biggest thing I could emphasize here is that should not be the case. It may look different, the things that we used to like to do, but there are adaptations to almost every single sport out there that can allow you to continue with whatever it was, from biking to team sports, basketball, soccer, swimming. There are some amazing adaptive swim coaches that I've seen have, patients that are fully hemiplegic, and they're teaching them to use that weak side. So these types of things are things that really should be thought about and probably worked into a therapy plan. So I have been pushing and pushing more and more of my patients, particularly my younger patients, to really use adaptive sports as a therapeutic modality. So we want to be incorporating that within that physical therapy regimen, that occupational therapy regimen. We've been talking about kind of adaptive music classes and people that have trouble crossing over and doing that stuff, getting into percussion and other things like that. But there are definitely ways that you can do this, and you can continue to be active and maintain your physical fitness, your ability to be active and keep going. And I think that incorporating them is a way to maintain that sense of activity and inclusion. So I would highly recommend continuing with any of these sports if possible. There's just a few things that that are out there. So adaptive sports, so for individuals with any sort of disability that are adapted from able-bodied sports. There's the Paralympics, parasports, so adapted from able-bodied sports, or they may be unique to Paralympics. And these are Paralympics comes from parallel, which would be where it is. And then there is the Special Olympics, which doesn't quite apply here, but is more for children and adults with intellectual disability. A good place to kind of look and see what's out there. So, often a lot of the big institutions do have groups. So for Boston area, there is a large adaptive sports group within the Spalding network. And so they have sites down in Cape Cod, one in Boston, right here. This is right outside of Spalding in Charlestown. This is a fully inclusive and accessible playground that they put in beforehand. But right to the left, they often have cycling, water sports, sailing, kayaking, that sort of thing. And then there's another one up on the North Shore that is sort of the base for some of the more winter sports, as well as some of the water sports. Within here, there's also a number of private organizations that have worked really hard to get people involved in adaptive sports. So Adaptive Sports New England, the person that founded that was a Paralympian with visual issues, and he works one-on-one with people to try to figure out the best way to get them involved in these. Otherwise, there's a few national ones, which I apologize, I can't remember the name. It's on the tip of my tongue. But there's some other very specific ones to different disabilities. I think maybe that's something I can talk with Kelly and ALD Connect, if maybe we can try to put together some more national references for people in terms of adaptive sports. So that was actually all I generally had here. It looks like Dr. Eichler answered most of those questions. So we have a couple other questions here. What balance exercises do you recommend? Is there evidence about what type of exercises are most effective in preventing falls? Yeah, so there are some. I would say that the majority of the stuff that we talk about when we think about our proprioceptive type work is really taxing the system. So what we end up seeing our therapists use a lot of are kind of those Bosu balls, and really taking yourself from wherever you are at the time. So if that's 2 feet standing still, putting some stress on the system there, moving forward, and just kind of increasing the stress on that system. When we think about our balance, the one thing that's really affected right now is our proprioceptive system, so where our body's in space. But right, our vestibular system, our visual system are all parts of that. And so the goal is to try to, one, increase kind of the network there and the efficiency of our proprioceptive system, but also maximize the other systems as well. So when we are using those other two, we're doing as well as possible. So I will say there's a few things out there. What I often recommend doing is having at least a few sessions with a therapist that can be really helpful to kind of go through and really focusing on those that proprioceptive work. Is there an average age of onset for AMN symptoms? Answer from Dr. Eichler onset can vary. Yeah, I would say from what I've seen, it has been pretty variable. I've seen patients, in their 18 or in their early, 18, 20 something with very subtle findings in terms of the proprioceptive issues. Often the spasticity doesn't come on until a bit later, but I definitely have seen a few patients as early as the 30s starting to see that tightness, if not a little bit earlier. And it definitely is different compared to the women. Yeah, I think it depends on how severe things are. My goal when I talk with patients, sorry, do you have any tips for men with AMN who have these symptoms? Call ahead when traveling, handicap placard. I think these things are all, some of this disease is a little insipid. It comes on slowly. And so I think sometimes it's hard. You end up in a spot where you haven't done some of this stuff. Thinking about like the handicap placard. I think it's something that can be really useful. And I come back to kind of our goals there. The point of that handicap placard and those spots up front are really, you may be able to ambulate, you may be able to walk from the back, but by the time you get up to the store, you get up to wherever you're looking to be, you're exhausted. And I think that, thinking about these types of things and just, using, if there's devices that are helpful, looking into spasticity and tone management with a physician that you're following with, can be really helpful in terms of maintaining that energy and allowing you to participate in the activity that you're looking to do. Because realistically, it's not the travel from the car to wherever you're looking to go. It's once you get there that you want to be able to do as best as possible. So I think having a good idea where you're going, I think the handicap placards are great. If you're really having issues and there have been falls and that type of thing, we want to prevent any type of further injury that really could set you back. So looking into any sort of assistive device, whether that's a cane, forearm crutches, I've had people do really well with. And then, at some point it may make sense to have a wheelchair moving forward. And there's a couple of really great options. I think there's one person that we follow that got the Freedom Grid chair. It's kind of an off-roading chair that you use kind of both hands this way, so you can really do whatever you're looking to do in it. So I think there's some great options in that realm. Yeah, in terms of annual monitoring, from my standpoint, it's often really function based. So if you're having issues, if there's things that are not going well, I recommend being seen. It's not necessarily like there's annual monitoring type things. From my standpoint, I definitely would recommend most people checking in regularly, just because I think there's probably some subtle functional deficits that sneak up on you that you don't necessarily notice unless you're talking with somebody and really working through what can be done. Yeah, so in terms of spasticity, the typical pattern that we see, what exercises for mobility spasticity, the typical pattern we see is often tightness within the adductors, the muscles that bring our knees together. That often is one of the more debilitating and challenging ones. We also see tightness within those hamstrings, and then typically within the gastroc soleus or our calf muscles. The things that I recommend, so, stretching of those adductors can be really helpful. There's been actually some really good studies, and this is maybe a little bit specific to where you are, about hippotherapy, so horse therapy for this type of stuff. It really actually helps with adductor tone. It also helps with balance and gait issue and proprioceptive issues. But really focusing your stretching on those adductors, pulling the knees together, and then the hamstrings are just can be such a brute of one. And the hard part with this, particularly if you think about when some of these symptoms start to come on, is that as early, almost all of our teenagers have issues with tight hamstrings just because they're growing so fast and our muscles don't quite keep up with our bones as they grow. And so the muscles and tendons get tight, our bones grow, and then they kind of catch up after. The hard part is after that teenage kind of growth spurt, sometimes that tightness in the hamstring just lingers, and then it just continues to get worse. So one of the easiest ones that we talk about on a regular basis is something called long sit. So if you're able to get yourself so your back is up against a wall or something, a wall or even a couch, just so you're not rolling it forward as you go through. You want to keep a nice flat back, and then sitting with those legs straight out and spending time there. And I think that's the biggest part here, and that's why we talk about this versus stretching. Is that if you're able to spend, an hour, half hour, 45 minutes, something like that in that position, it's going to be much better than if you do 5 minutes of much more intensive stretching. And so those are probably the two main things I would focus on. Outside of that, I think it is a little bit specific to you in terms of the strengthening aspect. We see a lot of hip flexor weakness that comes through. And so there's some devices that are helpful, not helpful in terms of hip flexion assist. They're often very bulky and a little bit challenging. So if you're able to maintain your strength, that sort of thing, but maintaining your flexibility is going to go a lot further in terms of your efficiency and that sort. So I think AMN gene therapy, I'll leave that to Dr. Eichler. Intrathecal backlift pump, and it's been a game changer for my stiffness. So I'm a huge proponent of it. I think it's just the intrathecal backlift pump. So the beauty of that is it's a small pump that sits underneath the abdomen, and then it delivers medication directly to the spinal column. And so you end up losing a lot of the symptoms that go along with oral medication. It's not going through the whole system. So sedation and other issues that may come from baclofen often are not a problem. Sometimes you can see a little bit of bladder retention, and that's often the most limiting factor that we see in terms of increasing the dose. But we're not typically on super high doses of baclofen elsewhere, and it's so titratable, which is one of the other really nice parts of it, is that you can change the dose depending on the time of day, and you're using micrograms as opposed to milligrams, so it's a much lower dose. I think intrathecal baclofen pumps are a great option. They're used a ton in multiple sclerosis, which is, I think, in terms of the gait patterns and the tightness patterns, very similar. So if it's really something that's affecting people and oral medication, injections, that kind of stuff hasn't been helpful, definitely something to consider discussing with your physician. So we talked a bit about the balance exercises, and sort of it's really just about increasing the stress on the system. I think that they're a little bit more difficult to explain here, but as you want to make sure you're doing them correctly to get the best benefit, and using a vestibular therapist or most physical therapists or somebody that would be able to do one or a couple sessions just to go through and kind of do some testing and see where the best work would be. But if things are going pretty well and we're not seeing therapy on a regular basis or having regular falls, getting those half Bosu balls out and spending time trying to standing one single leg, closing your eyes, taking out that visual input can be really helpful. And then in terms of, do women with ALD get affected by the bowel and bladder, or only men? Women do get affected. It's often later on in the course, and certainly something that we have discussions about on a regular basis. But I will leave that to, I think, Dr. Gomery and the rest of the team for today. So I hope that was somewhat helpful. Here's one last question. Yeah, so in terms of medications, I think there's a couple different strategies. I often do start with patients taking medication at night. Clonazepam and diazepam are probably the two most common benzodiazepines that get used. Having sedation and sleepiness from those is definitely something that can happen. Valium or diazepam has more of a effect on the muscular system, but it also has a longer half-life. And so you may see symptoms. If you're already seeing symptoms within the day from the clonazepam, and some of it depends on what the dose is and what time you're taking it. But
taking the strategy of taking it at night is really helpful. Often with spasticity in particular, we DC tightness at night. We often all sort of sleep in a little bit of a crunched up. Our hamstrings are a little bit tighter. Our knees are together. Often our feet are pushing down. And those are kind of the patterns that we're trying to avoid. So having some relaxation into the muscles at night can be really helpful. But if you're having sleepiness, if you're having issues during the day, sometimes those benzodiazepines in particular can affect our sleep cycle and how we're getting into REM and other things like that. And so there's other options. Diazepam could be a try to see if it just affects you a little bit differently. The other option would be to switching to a totally different type of medication. Backlift is often my first line for most patients. There's a few other ones out there. From tizanidine on the adult side, can affect blood pressure, doesn't often have as much sedation. And then dantrolene is the other one. I often don't use a ton. It does need regular monitoring in terms of your liver function. But it's the one medication that actually works on the peripheral system versus centrally when we talk about tone management. So if you're having issues with sedation or you're having issues not tolerating the medications due to tiredness, that may be a good option as well. But again, if there's a number of options out there, I think at this point. So if you're having side effects and you're seeing issues with it, talking to your physician and just seeing if there's a different medication that you could look at would be helpful. In terms of young AMN males, what can you focus on? I think the better shape you're in going into this, the better you're going to do on the back end. So I don't think there's anything absolutely. The things that we see are tightness. So if you're able to increase your flexibility, your range of motion, that type of stuff, we see weakness within the legs if you're able to increase your strength. And we see balance issues. So focusing on that as you go through, typically when we're young and we work out, it's often a lot of strength training, not as much flexibility work, and definitely very little balance stuff. So if you're able to work those into your training regimen, I think that's an important aspect. As the higher you're able to start, if you kind of drop off, if you have more neurons kind of firing in the right direction there, the better you're going to do. So that's 11:54. We'll give it 1 minute. Thank you, everybody, and enjoy the rest of the day.